Well, thank you, Rebecca, for the kind introduction, and thank you to the BHIPP team for inviting me to talk for your team and the opportunity to speak at your Resiliency Break Hour, and happy Friday to everyone. I will not actually see anyone I only see you, Rebecca, but you're monitoring the chat, is my understanding, and if there's questions, hopefully we'll have those available. I would imagine we do that at the end of the presentation. Is that correct? Okay.
That is correct.
Yep. I like interactive opportunities, so hopefully we'll get some of those. So yeah, the topic is on autism spectrum disorder, and the target is really to think about primary care and how can we think about opportunities in primary care settings. Okay, I know my slide was moving earlier, so let's see. We practiced it earlier. You are sharing the screen. It may take a second to move. All right, okay, so I have no disclosures. Okay, so the learner objectives for this afternoon are to define autism as it's currently defined in DSM-5, to describe two strategies that are used in the detection of autism spectrum disorder, and to give a list of screening tools that are available. And the third part of my presentation is to delve a little bit into the importance of the life course approach in autism and give you a few examples on how to support children and families. So as I stated, the agenda item is going to focus first on definition. I want to share a bit of updated information on prevalence and trends. I have learned, I think, in the training here, particularly credit to Dr. Landa, who I will show you videos from, really working on training the eye on how can we detect autism, even if we don't have a lot of time. And again, we cannot just rely on that only, but I'll give you a framework on how to train and observe. And then the last part is autism in the medical home. Okay. So before we get started with the definition as it is in the DSM-5, I wanted to actually bring to your attention a series of papers that were published in this month of pediatrics. And it's a supplemental issue in the journal where the AIRP, which is an organization that delves into research on physical issues related to autism, and they published a paper on, the title is actually Do No Harm, Suggestions Regarding Respectful Autism Language Use. This is a paper, like I said, was published this month, where there is an opportunity for us to think about wording, and I actually teach this concept to medical students as well. Wording and language matters. So there are suggestions regarding changing terminology, and I just put a few up here from the paper on thinking about how do we describe difficulties and challenges in the area of autism. And for those of you who are familiar with the difference between first person versus identity first language. So person first language would be a person has autism. Identity first language would be the autistic person. There is definitely opportunity, I think, for discussion and opportunity to learn from people with autism who will tell us. And as you may have heard the term, nothing about us without us. That was actually a term that was coined by an disability advocate from South Africa many years ago. And it's reached, I think, the autism community regarding how do we think about language, respectful use of language. So maybe more to come as we are looking forward to revisions of autism descriptions, even in DSM-5. But today I am going to use DSM-5 language. And just to make sure, so we may, if we don't have time for it today, but I think it is, again, I teach this to our Hopkins medical student team, thinking about the medical versus social model of disability. So when we think about disability as part of you, and the goal is for you to, quote, be fixed, versus the social model of disability, where we are really thinking about how can we accommodate as a society or individuals to ensure that we make room for neurodiversity. So it is, the idea is that we really look at societal factors, not as much as individuals. So that is a discussion that is really worth having in the context of autism as well. So this is an orientation slide regarding the diagnosis of autism. As you can tell from the slide, there are kind of two, I call them buckets, criteria A and criterion B. We'll delve into that in a moment. In addition to autism, it is important, and this is really how it's set up in DSM-5, that we look for what else is going on in addition to core features of autism. And working with children and individuals over time, it is important for us to not only look at core features of autism, but again, what else do we identify as areas of need? So in DSM language, it's called specifiers. So thinking about children's language and their ability to express themselves verbally, and how do they understand when we offer directions, so their receptive language skills. As time goes on, thinking about intellectual and adaptive function, which I think in part drives a little bit level of support that individuals with autism may need as they get older. And then the bottom part of the, we call it specifier section of DSM, has us think about co-occurring conditions, and many of them live in mental health. So as you can tell from the slide, co-occurring conditions such as ADHD, anxiety, mood disorders, these are all very relevant and possibly treatable aspects for children with ASD. I won't delve much into medical conditions today, but we as physicians are tasked in some ways with asking the question, why did this happen? And that is not the focus for today as much, but something that we as pediatricians and physicians take on the journey with families. So we could spend probably a whole hour thinking about how do we think about autism signs at different ages, but the DSM-5 actually gives us an opportunity to think about it in the context of a spectrum of difficulties at different ages. So these are just some examples, but criterion A looks for persistent differences in social communication and social interaction across multiple contexts, where we evaluate social emotional reciprocity. How do children use nonverbal communication behaviors such as eye contact, use of facial expressions, body language, and gestures, and how do they use them? How do they integrate them when we observe them? And then the development, maintaining, and understanding of relationships. And this is obviously, as you can imagine, when we see toddlers, that is a different evaluation as opposed to when we see children, let's say in preschool or school age. Criterion B for autism pertains to restricted repetitive behaviors, and we need to be able to identify at least 2 of 4, either by history or by clinical examination. And as you can tell from the slide, the list includes stereotyped repetitive movements, use of objects or speech. So we would look for atypical play, such as lining up of objects, atypical play with toys, and echolalia, which is repetition of speech, is coded under this item in DSM-5 as well. Insistent on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior are evaluated in this section. And then for children that may initially engage in restricted repetitive play, as we look for these type of concerns, as children get older, we would look for unusual or intense interest or objects of interest The DSM-5, this is the first time that DSM looks for hyper or hyposensitivity to sensory input. So this is new actually in the DSM-5, but we know many children with autism spectrum disorder will have an unusual, atypical response to sensory input. They may be sensory seeking or sensory avoiding. I'm not delving a lot of time into this because I want to make sure that we have time to observe a few things on our end as well. At this point, many parents ask us, tell me, what is the severity of my child's autism? And at this point, the way that we have organized it is really looking for how much support do individuals need over time. And again, this is you can find this in DSM-5 in more detail. A few slides, you may have heard, or periodically there are publications from the CDC on prevalence. So in December of 2021, new data came out on prevalence of autism, and we now have opportunity to look at prevalence data at ages 4 and 8. So the most updated information regarding prevalence is that 1 in 44 8-year-old children have a diagnosis of autism. And this has been well known over studying this from an epidemiology perspective, but it's more common in boys than girls. And that has persistently been demonstrated with epidemiology data. A little bit of information about trends. Let me just actually go to the next slide for that. With a lot of work that has gone into early recognition and in some ways public health campaigns, so you may be familiar with the CDC Act Early campaign, which has put out information regarding early signs and symptoms of autism. We have been able to move the needle on early identification. We also have been able to move the needle some on narrowing a gap between different race and ethnicities. So as you can tell from this slide that we used to have significant discrepancies in early identification of autism among various racial ethnic groups, but we have done a better job with that over time. There still are concerns, and this is a slide that shows that there still are discrepancies, particularly in our African American community, where children, African American children or Black children are more commonly identified with intellectual disability and autism. And this is from the most updated data that is put forth by the CDC. This is a very busy slide, and I don't want to overwhelm the group here, but it gives you an opportunity to look at how we have collected data and how we actually have moved the needle on early identification. So what you see in this slide is 8 and 4-year-old data. We're going to look at Maryland. It is interesting because Maryland is actually one of the states in the country where data have been collected by the CDC, I think, since its inception in 2000. And what we see here is that we are doing a better job over time with early identification. However, if you look at the blue line, we also know that not all children are going to be identified by even age 4, and that we see an ongoing increase, or it's not really an increase because this is cumulative incidence data, but we see that not all children are identified actually at age 4. So that does lead us to think about, when we screen for autism, even though the American Academy of Pediatrics has guidelines to screen at ages 18 months and 2, we know that not all children will be identified that early. So I'll give some information on that as well. So in terms of the approach in primary care and what has the American Academy of Pediatrics guided us on regarding early identification from autism, and if you read up on the most current guidelines, and I'll share with you a little bit more about those. We are kind of learning from research that targeted screening at 18 and 24 months is not going to be enough, and that what we need to do in addition to screening is engage in surveillance, which basically means asking parents to question, are you concerned about your child's development? And if so, what part of development are you concerned about? What I've really learned in my training over time is training our own eyes. Now, again, if you're in a busy primary care setting, you may not catch that, but I do think understanding autism by learning to observe what you can observe actually has helped me understand autism and early identification better. So I just mentioned developmental surveillance. The American Academy of Pediatrics asks us to do targeted screening for autism at 18 and 24 months. And I want to spend some time during this presentation today on, quote, training the eye. The CDC, and actually there was another, it sounds like a lot of information that I provide today is in some ways hot off the press, updated information on what's going on in the area of autism. But the CDC, in conjunction with the American Academy of Pediatrics, published a paper on the importance of surveillance. And they have looked and are publishing on questions at different ages that will help us to learn about possible warning signs at different ages. So here, this is adapted from the CDC Act Early website, but as early as 9 months, we may see signs that pertain to a child does not respond to his or her name. We want to make sure that the child hears well, but that is, in my experience, actually a pretty sensitive question to ask. And if there is concern, we need to figure out what that means. Children with autism may have more difficulty showing facial expressions. Again, I call it the mini mental status exam in young children. We think of mental status exam often in older children, but we really can look in young children as well for a nonverbal communication that involves facial expression. Even though autism has taken out language development, so it's now a specifier, we know that young children should be able to engage in what we consider a sharing of vocal sounds, so that vocal tenors that you see as early as 4 months actually, and reciprocal smiling and other nonverbal communication strategies that are reciprocal in nature. By 12 months, many of you may enjoy that hide and seek, like little pat a cake or peekaboo game that we should see as early as 12 months. So the lack of interactive games could be a red flag for autism. And we are going to see a little bit in a video in the next few minutes about nonverbal communication that could lead us to paying attention to young children's nonverbal communication, such as use of gestures. So by 15 months, children should come up to us and show their favorite toy. At 18 months, they should be able to show and share something in the environment that they want us to see. By 24 months, they should pick up when others are expressing emotion and respond to it. And by 2.5, we actually have a fairly extensive and beautiful play repertoire that we should be able to see in typically developing children. Children with autism may pretend play as well, but oftentimes their pretend play is more limited and maybe more contrived when we see it happen. This slide has a lot of information as well, and I know that my slides will be available, so it's not my goal to go through all the items here, but it's another list of possible warning signs that are published by the CDC. I think it is important, if you look at an item on this list that it is important to look at any of this in the context of what else is going on. So example, a child who avoids or doesn't keep eye contact, that could be a sign of autism, but it could also be a sign of anxiety. So it is really important as we go through our kind of differential diagnosis, we call it, that we think, how can what we see be explained? Because it's not always autism. As a matter of fact, if you look at the screening tools that we use, we actually over-identify autism if you were to use those. I'll delve into that in a minute. Okay, here's the slide on autism screening tools. So the most common screening tool that we have available to us right now is the Modified Checklist for Autism. And I always teach my trainees, make sure you are aware of the revised version with a follow-up questionnaire. This is a tool that is most commonly used now in primary care. It's designed for children ages 16 to 30 months. It's free, it takes little time to complete, and so in that sense, it is great that we have it. What we are learning, though, from research on the use of the tool and its implication, that it's actually far from perfectly identifying children. So we are in need of better screening tools, and there's lots of research going on in use of better screening tools. So I'm going to say stay tuned on those. This is taken from the slide, or the information is taken from an American Academy of Pediatrics initiative that's called screeningtime.org. I welcome you to take a look at that website. It doesn't only have screening tools for autism, but also for other developmental conditions and also mental health screening tools available. So these are just three that I took from this website. So the SCQ is actually designed for children that are older, and the POSI SWIC is actually a newer tool that looks for possible signs and symptoms of autism in the context of other developmental screening items. And that is a free tool that you should have access to. I don't think there's a whole lot of research that we have available on the POSI, but more to come on screening and autism, no question. So here is
this 14-month-old child has a mild motor delay, but does not show signs of ASD. As he explores the new toy, he remains aware of the people nearby. He checks in with his mother behind him to ensure that she also sees the toy. Next, he shows that he understands the social communicative meaning of the woman's pointing gesture by immediately looking at the sticker. Then he looks over at another sticker she had pointed out before. He continues the woman's topic of communication as he points to the Tigger sticker. He shows the motivation to maintain social engagement with others and the ability to communicate using coordinated gaze, vocalization, and gesture.
All right. I think the narrative was there before I could introduce this slide. So this is the voice of Dr. Landa, who created a video tutorial with the opportunity for us to look at some of those core features of autism that we look for in very young children. So I won't play this again, but I would encourage everyone to look at it's a 10-minute video tutorial that gives you a lot of information just from doing a quick review of what you just saw. So part of what we look for is called joint attention. And the way that I explain that to trainees is basically, do you see what I see? And it has two components to it. Does a child follow our attention? So when we point to a picture, for example, does a child follow our lead and look at what we point at? And then the other component of joint attention is what's called initiation of joint attention. And what that means is, do children use strategies to let us pay attention to something that they want to show and share with us? And it could be as simple as looking at an object, looking then at a person, and then looking back at an object that they want to share with us. So these are real opportunities, I think, for us to train our ear and our eye. It can be pretty quick and pretty subtle at times, but this is what I've learned, and this is what we actually do when we evaluate children for autism. We look for these core features of communication that go beyond, I call it the word level. So let's look at another video.
This 14-month-old shows signs of ASD. First, he flaps his hands while enjoying the bubbles. He does not share his enjoyment by looking at the man. He does not respond to his name. Although he looks at the man's pointed finger, he does not follow the direction of the man's gesture to locate the object of the man's attention.
So as you can tell from this video clip, is this child does not necessarily use eye contact or facial expression directed towards the examiner and does not follow the examiner's lead.
This 14-month-old child shows signs of ASD. Notice how his attention is so focused on the toy that he does not interact with the people nearby. He does not share his attention with others. His exploration of the toy is also unusual. He drops the toy onto the table and watches it move. When the toy stops moving, he does not use eye contact, vocalization, or gesture to ask for help. He also tenses his body and mouth in an unusual way. Even though the lady is talking to him, he shows no interest in her. He does not seem to understand that her gesture is an offer to help him. He does not check in with the lady or his mother to see whether they are paying attention to the toy that he is enjoying.
All right, so these I think are just three beautiful kind of short clips, but it really gives you an opportunity. I didn't mention thinking about criterion A that I talked about earlier in criterion B, the presence of repetitive behaviors. And again, it's not specific for autism, but we see other conditions where hand movements or hand flapping could occur. So you cannot rely just on one sign or symptoms. You need to evaluate those in the context of what else you hear from the parent's description and what we see when we engage in interaction with children. So I hope I gave you a flavor of observation, and like I said, there is opportunity to learn more by looking at video material online. So the third part of my presentation is focusing on autism in the medical home. So I know for those of us who are pediatricians, I think one of the biggest messages is always parent knows best. Now, not always, I would say, but listening to parental concerns is always the safest and most important thing to do. So when parents bring concerns to our attention, we need to listen and take it to the next step. And this is truly what surveillance in development involves asking questions. Do you have concerns about your child's development? If so, delve into more detail as to what those specific concerns are, but also really using our clinical skills, even when parents do not bring concerns to us. And this may be a question that you have, at what age do parents actually bring concerns regarding autism to clinicians? I think that needle has moved backwards a little bit because there is much more information available online regarding early signs and symptoms of autism. So often parents come to us and say, well, we saw information about this online, or we saw a video. So parents may bring this to us sooner because of more information available to families. So I mentioned before screening using the MCHAT. There is a screening guideline for it. When children fail the MCHAT, depending on the score of the screen, oftentimes it is good to refer children for further evaluation. If it's not autism, it may be another developmental delay that needs further attention. The other piece that I think is really important, in addition to referring for additional evaluation, is to refer for early intervention. Early intervention does not require a diagnosis at all. There are criteria used by the state of Maryland that will look further into whether a child is eligible for early intervention, but a child does not need any diagnosis, such as autism, to receive services under the umbrella of infants and toddlers. There are some, I think one of the challenges, and there's many publications on the topic of concern with access to identification and access to services regarding autism. So there may be people in the audience that I'm talking to today who may feel comfortable with offering a preliminary diagnosis of autism if particularly waitlists when they're long and when we want to ensure that families get the right guidance at the right time. I have not really engaged much in conversation with primary care colleagues how comfortable they would be with that, but there definitely are voices going up on training primary care physicians to feel more comfortable with this. When the MCHAT is negative, it is really important, as I showed you in the slide earlier, not every child with autism will be identified even by the age of 4, right? So we need to ongoingly monitor and pay attention to children's social development and social communication and play and peer interaction to make sure. I would say children sometimes go under the radar for quite some time before we pick up on the more subtle signs of autism. I mentioned in an earlier slide that the MCHAT is actually designed for children 16 months to 30 months, and this would be developmental age. We need more tools for autism at different ages. Not all children are captured early, so surveillance is important. So the previous, the section I've talked about so far is really focused on surveillance, screening, and the early detection, but primary care physicians will see children in their practice after a diagnosis of autism has been offered. So kind of thinking about what are the things that we as pediatricians or pediatric healthcare providers can do to assist families when they come, let's say, into our offices. So here are just some suggestions. This is not an extensive list that I've created, but we know for some of my patients, I've learned that parents use pictorial communication support, like just putting on the calendar with a picture of the person they're going to see, or creating a social story around, going to the doctor. I've learned just empirically that actually having doctor tools for kids to play with at home really make them more comfortable when they come see us, because they've seen that stethoscope and they kind of know what it's for. Timing of an appointment can really be, I think, critical in the sense that, when you are having a busy practice and you invite a child with autism who may have, let's say, sensory differences, maybe setting up an appointment early in the day or very late in the day where it's not as crowded in the office can really be a nice accommodation to offer. I mentioned visual support, and in the back of my slides, there are some tools that are available for how do you create visual support, and sometimes parents have them that they can bring. I've learned really how helpful it is when parents actually bring toys to the visit. Yesterday, I saw a little girl, and the parents definitely prepared, and her preferred toys actually were in the toy bag, and I could use them to engage the child during the visit. So that was really nice. Limiting transitions. I'm kind of always aware when we set up our clinic space, how many transitions do our families need to go through before they then see us. So we try to minimize the number of transitions as much as possible. And the simple thing, when the nurses at CART triage our patients, they leave the patient in the triage room, let us know right away so we can limit number of transitions in our setup as well. And I find that actually a very helpful accommodation, because we limit like going back and forth between different parts in the building. So one of the other, I think, main things that primary care physicians often get involved with is the addressing of co-occurring conditions. I want to spend a little bit of time on that. So what are co-occurring conditions in autism? They are numerous, and this list is probably not comprehensive, but we kind of think about it as medical comorbidities, mental health comorbidities, and then learning or school-based comorbidities, co-occurring conditions that and I think comorbidities is the word that we should not use. Co-occurring conditions is the better word to use. But really looking at children and what their needs are in all these domains is very important. So this is the challenge. And for those of us who work with families with autism, it's like, where do we start, right? What are the most important kind of things that families need at what point in time? And this is where I think the life course approach in autism is so important. And we are fortunate at CART to work with other professionals. We have a team approach, and I really appreciate members on my team to help with any of what you see on this list, including paying attention to family and family stress. What can we do to make sure that resources get into the hands of families when they need them? But the list often is long, and how can we prioritize? So this is an example that I give you. Actually, it was one of our social work team members at CART who presented this slide one day. I'm like, I like this. What is most important for a family? They identify sleep. What more specifically is it that we can do as professionals, but really also let's make a plan for how to address it and who is going to be responsible for execution of the plan, and helping families in some ways keeping up with all the referrals that we make or all the suggestions that we offer, and make sure that in the end we get things done. So another important component, I think about this a lot when we do evaluations at our center. We come up with lengthy reports with a lot of information in there, but how can we support the family when they walk out of our center with the diagnosis of autism? And I do think that primary care physicians have a really important and useful role to play, because you are that place where people come to for pretty much help in lots of different ways. So asking families to bring information that they would like to process, I think, can be helpful. And it could pertain to, let's say, Kennedy Krieger records, but sometimes it's more like school records. What is going on? How are children supported? And really I do this, I think, a lot when I see families over time, is helping them understand information. It is important to think about safety, and we have a lot of resources that we share with families when safety is of concern, so wandering or self-injurious behaviors. And then the term scary, when parents need support because there is an unsafe environment, either for children or for families, we need to make sure we don't overlook that. As time goes on, family impacts, I'll show you one slide, and I'm looking at my time. I want to make sure that I give you a slide that I think really gives you an insight in some ways the complicated networks and the complicated care model that we in some ways use, and how much room for improvement there is. I briefly mentioned screening of siblings just because there's higher risk for siblings. Once you have a child in the family with autism, we want to screen siblings and help monitor their developments because siblings are at higher risk for autism. I'm gonna not delve a whole lot into it, but I have learned over time the importance of shared decision making. In some ways, like the slide I showed earlier, what is your priority? Let's think about what it is that you would like for us to help address and kind of chunk it in doable size kind of buckets, but really giving families room to share, where they are and how we can think about. And this can pertain to medicine. It could pertain to treatment. It could pertain to something like school placement. And what I found really important to make room for is discussion on complementary and integrated medicines. There are many, many toolkits out there that help us with how do we engage in shared decision-making conversations. If you have a need for those, we can support you in finding them. This is actually from a paper that really this visual struck me. If you think about a life course in autism, this is from a paper that was published, I think in the month of January. It is by the Lancet Commission on Autism. It's written by leaders internationally in the field of autism, and it's actually a really comprehensive review of autism and kind of the current state and both clinical as well as research, kind of where are areas that we need to improve upon. But when you look at I'm going to say, look at the blue, which is the family circle. Many of us, think of as children get older and they become teenagers and they leave the home, the role of family is there, but the role of family really oftentimes gets smaller, right? So for kids with autism, role of family and family support stays very high. The other piece would be the role of community. We think of young children and think about childcare and programs that we have for young children, but the needs for individuals with autism as to become adults and the community support, and do we truly have them? I think this is a big area of where need is identified and important to attend to. And this is something that or I would say most families that I engage with, talking about the transition from childhood into adulthood. What's there for my child when he or she becomes an adult? So my last slide, this is kind of probably overwhelmingly busy, but it is actually a visual that when I saw this in a presentation one time, really like, oh yeah, this is why it's so complicated. So this actually is a drawing on the right. I'm just going to have you focus to the one. We actually published a small paper on this concept of the drawing she kept. But the one on the right was actually, I was reading up on this. This was the mother was actually preparing to do a talk for a primary care audience several years back. Now her child doesn't have autism, but she started to think about how do I explain to anyone truthfully the challenges that I face with my family, and how do I keep this all straight, right? So I think the circle, I didn't count, but I think her circle became as big as 70 entries, 70. How can you navigate a complicated system, and how can we as providers, kind of think about this? In some ways, the networks are there, the networks are available, but how do we synchronize the care for children with autism? I think that still is a very challenging area. We throw a lot at our families regarding, oh, do this, do that. But how do we guide families, and how do we know that we support them rather than overwhelm them? So the picture on the left is actually just a drawing that we put in our paper that was focused on actually cerebral palsy. I think there's more need for helping families. Care coordination is not something that is easily done and also not, unfortunately, very well reimbursed. But I know there are programs in Maryland. I'm actually looking to BHIPP. Maybe BHIPP gives us more answers on how to really help families synchronize care. I know about the VIP Kids program. I would imagine that this is a need that many families have that that I would love to find ways to support families better in. So Rebecca, I know you are in view. I just want to finish. This is a slide from a New York Times article that that was a mother who was interviewed about looking into the future for a child with autism. And I usually have somebody in the audience read, but I think for the sake of time, it's a very moving story. Actually, it really for me, it describes in some ways the essence of what we need to do, and that's listen to parents, but also listen to children and making sure that we don't miss the boat. And this statement, I think, really gives us an opportunity to think about making sure we don't miss essential information that often children bring us. You know, we talk a lot to parents, but children tell us truth, right? So I won't read it for the sake of time, but the slide deck, I think, will stay around. So please read Ethan Vision's statement and what his mom had to say about it. All right, I'm going to stop talking. I want to make sure that there's some room for questions at this point.
Well, thank you, Dr. Wilmsbluth. This has been a wonderful presentation. I'm sure the audience is really appreciative of your time today, and we are certainly here at BHIPP. To your comment about any organizations that support families with children who have autism, we have had some connections with a program that's local called Pathfinders for Autism. And so we will be sharing some of those resources when we send out the slides as well, because they do have some resources specific to primary care and kind of healthcare situations. So, yep, and you've already got that here. So that's wonderful.
I would say we are fortunate in the state of Maryland to have Pathfinders for Autism as a resource, and I very often guide families to the website because they have incredible resources for the state of Maryland. One little pitch that I forgot to mention because I didn't get through my resources section, the AAP actually this month, let me see here. Yeah, because it's Autism Acceptance Month, the AAP actually is offering an online course regarding caring for children with autism. And lo and behold, it's free until, I hope this date is correct because it would have been outdated, but apparently until April of next year, we can access this training opportunity. So that's actually great to identify. And there's lots of great information out there. How do we bring it in the hands of people who can then use it, right? So I just wanted to make that pitch from the AAP. Yeah.
Wonderful. Thank you for sharing that. Yeah, these slides and resources will be available on our website. And the link there is in the chat. They'll be available next week. So thank you for sharing that. We do have a few questions already, so we'll go ahead and jump in, but I do want to encourage our audience to keep entering those questions into the chat if you have any. So we had one question a bit earlier about a specific screening tool. Do you use the ASQ?
So screening tools get acronyms and then, you know, they get a life of its own. So I think I know of two ASQs off the bat. Like we actually get really confused and like, which ASQ are you talking about? But I think the ASQ that you may refer to is the screening tool that is used often by primary care physicians for development, but not necessarily autism. And there's some research that looked into, you know, is an ASQ picking up autism? And if I am stating this correctly, the answer is no, you really do need to do specific autism or autism specific screening. So ASQ would be Ages and Stages Questionnaire. And I know there's an ASQ that actually lives in suicide screening too. So we have to like be careful which ASQ we're talking about, but those are the two that I'm aware of.
Wonderful. Thank you for answering that. Another question here, if a pediatrician provides an autism diagnosis, will the child be able to receive services, or will the child need an official diagnosis from a provider like KKI?
I love this question. And one of my homeworks, excuse me, I'm going to say the answer is yes. But when I justify, for example, ABA therapy, excuse me, it asks for a qualified professional. So I am going to go on the assumption that a pediatrician is a qualified examiner to fill out, because it always comes with paperwork, right? And you need to document a lot. That is the problem. But if anyone has had any additional questions about that, email me, and I can, in some ways, guide people on that topic. But it's a really good question, because if we can offer this opportunity for primary care physicians, what does it get you, right? Or what does it get a family? But I would say that should be an opportunity to open up doors for services. Yeah.
Right. Another question here. So we did have a webinar with Pathfinders for Autism a while back, more pertaining to older patients with autism. And so this question is wondering, what can we do for younger children to help them feel comfortable, specifically in emergency situations? And I believe this is a rescue squad or EMT professional asking this question.
Right. So that's also a really good question. I know Pathfinders for Autism has done training for pretty much different audiences, including emergency room providers. So they, I think, have a curriculum that lives, that I was at some point able to actually learn, like I was in the audience one day when they were training people on autism, particularly in emergency room settings. So I think that will be the place where I would go to if there's, like, let's say, a specific need for training. I think one of the things that I find really helpful, as a matter of fact, I remember when I was a resident, I remember I was in the emergency room. It's like, oh, you're going to see a child with autism. I'm like, I had no idea, honestly. But what are good questions to ask before you enter the room, right? So one question I think is really helpful is, how does a child communicate, or what are a child's preferences? And sometimes I am, like, surprised with, you would think a child with autism is going to have a very hard time with your physical exam, but because they love sensory input and I do a belly check, it's the time they relax. And so it's really hard to predict, but asking families questions and have some toys, I know Sinai Hospital, I think, have a good reputation. They really did, I think they may have done a QI project in their emergency room and created tools. And I know there's been initiative at Hopkins in the ER there as well to make an environment more autism friendly. So
right.
I don't know,
so it's not,
but I would say go to Pathfinders if your team needs additional training.
right. That's great advice, though, to just kind of do a temperature check for how that child might like to communicate. So that's wonderful. And I do want to mention we have the evaluation link in the chat now. So if you'd like to receive CME or CEU certificates for today, please do fill that out. But we do like any feedback either way. So please do fill that out before you leave. Another question here, where would you recommend sending an adolescent patient for an ASD evaluation, maybe even 18 or older?
Right, very good question. And that comes up. It is, I don't think, unfortunately, Kennedy Krieger, they draw the line. Actually, different professional, different groups within our system have their own guidelines regarding age. I don't know exactly. I know Bayview has a program that is focused. I know Shepherd Pratt has a newer program that they are launching. So I know those are two that I can come up with right, from the start. But those would be the two. Again, would this be a good Pathfinders question? This is just on the top of my head, like this is what I would say, like check those places out. Yeah.
Okay, great.
It is,
And
by the way, So it is a diagnosis across the lifespan. In other words, we actually more often ask, families tell me, they're like, well, I've not been diagnosed with autism, but there are parts of me that make me wonder, we have this concept of broad autism phenotype where you're not necessarily have a diagnosis of autism, but there may be parts of you that are like, no real interest in social activities much, or we do get parents to tell us, as we evaluate their children, they kind of like, I kind of can relate to my child in some ways. So, yeah.
Wonderful. So our next question here, also kind of about this age limit, is there an age limit to ABA?
Can we skip that question? I don't think there is. I think many of us would say it lives in uh, early intervention, and there's a lot of discussion even in our own group about how do we guide families on interventions. There's actually a whole lot to learn. There's this term called NDBI, Natural Developmental Behavioral Interventions, that have ABA components, but insurance allows us to write a prescription for ABA. There's not really an age limit. As a matter of fact, I had an adolescent that I've worked with who had some kind of temporary ABA support, and that was incredibly helpful. Now, many adolescents, for example, become eligible, or they have been eligible, but they are, on the list of getting autism waiver. So it really depends, I think, on what families are looking for, and what are the goals, for the intervention. So it's not a straight answer that I'm giving. I think of ABA often more in the context of younger ages, but it's not exclusively for that age group. We should get an ABA provider to help answer that question too. Yeah.
Sounds great. So I'm not seeing any other questions at the moment. I do just want to thank everyone for your time today, and especially Dr. Boomsflute. Do you have any closing thoughts before we end our session today?
I think I had a Pearl slide. Maybe I can find that real quick to make sure that I have addressed. Oh, and this is this is actually a real, when you think of outcome, in the end, we need to really think about resiliency and strength. So this is kind of, I found this one time, I'm like, this is a funny slide, but it really speaks to, you can, let's say, work on something, but really, what does it lead us to? So when I think about working with families, it's like, what brings us happiness? What is it that a child can do that is fun? What is it? We are trained in medicine to be deficit thinkers, right? So we think about what's wrong, but on the other hand, what's going well, and what brings a child or what brings a family happiness. So when I get a request for, can you support me in, signing up for swimming, or can you make sure that the list funding, which is funding that families can apply for certain activities, that is really important. And we need to really think more about, I think that is where I didn't really show the disability model by the WHO, but they really are more strength holistic focused. That is really a good lens to use. So, pearls. And I know I'm running like 1 minute late, but I'm kind of happy that I didn't get too much over time. So, the identification of autism requires surveillance, screening, and clinical evaluation beyond the recommended ages, and actually before as well, right? Because we know that sometimes you can see signs of autism way before those screening ages. Medical and mental health conditions do often occur in autism and are often treated and identified in a medical home. And really thinking about shared decision making is an effective approach to discussing therapies and interventions in autism.
Yeah. Wonderful. Well, we have a flood of thank you and appreciation coming through in the chat. So just wanted to let you know we're seeing a lot of appreciation for this today, and thank you again for your time, everyone.
And I appreciate having had the opportunity. So thank you for inviting me.
Thank you. Take care.